So I'm going to get started. I know that there's somebody, one of our witnesses in the security line. So I'll just get us started because there's a lot of folks here and we want to make sure we get everybody a chance to participate today. So first of all, good morning, everybody. Good morning. And thank you all for participating in today's roundtable, especially those of you who've traveled to be here. I know that many of you have personal experience with this issue that we're covering today, and I appreciate you being here to share your experiences and your expertise today. We have so many brilliant individuals at this table, and I want to make sure that we hear from all of you, so I'll keep my remarks brief. It's critical that we protect veterans' freedom to build their families on their own terms, and that they have access to any care or treatment that they need to fulfill that. We have asked veterans to sacrifice their bodies and their best reproductive years in service to our nation. In return, it is essential that VA upholds our promise to veterans and provides all the care and resources they need when they're ready to build their families. Many of you know, either firsthand or from veterans, that this is not always the case under current policies and law. VA's current eligibility requirement that a veteran's infertility diagnosis must be directly linked to a service-connected disability is leaving many veterans ineligible for assisted reproductive technologies, including IVF. Infertility is a complex diagnosis that can stem from a variety of conditions. And many veterans have a diagnosis of unexplained infertility, which is inherently impossible to link to a service-connected condition. And our understanding of infertility continues to evolve. And in my view, and in the view of many Democratic members of Congress, this is not right. We need to focus on expanding access to IVF services to any veteran who needs them, regardless of what caused their infertility and whether they can prove it was service-connected. That is why my colleagues, Congresswoman Brownlee and Dr. Morrison, Congresswoman Dr. Morrison, have also introduced legislation to either remove service-connected requirement, service-connected requirement entirely, or expand presumptions of service connected to infertility. To expand presumptions of service connection to include infertility to ensure more veterans are eligible for IVF through VA. Now, some of our Republican colleagues and President Trump claim that they support IVF. However, their voting records and administrative actions so far don't back this up. Between refusing to prioritize legislation to increase access to IVF for veterans and service members, issuing executive orders that don't actually improve access to IVF, and pushing unhelpful and misleading policies like restorative reproductive medicine, it's clear that Republican members of Congress are not serious about expanding access to IVF. Now, finally, I want to acknowledge that our conversation on IVF does not exist in a vacuum. Other policy decisions, like VA's recent reinstatement of a near total ban on abortion, also affect access to IVF services. Veterans deserve access to the full spectrum of reproductive health care that they have earned, and that includes both abortion and IVF when they need it. So I want to thank you all for being here. I want to give you all a chance to introduce yourselves and provide a few opening thoughts. And then we'll move on to time for my colleagues when I anticipate a couple of them will be here to ask questions and to engage in discussion. I'll start with, now, how close are we to having?
Okay, we'll slaughter him. We need to.
Okay,
Yeah.
great. So I'm going to start with my participants to the left, and why don't we just have brief introductions of who you all are, and we'll. Oh, they're going to have remarks as well. So they'll have opening remarks? Okay. Well, we'll just start with Ms. Hundrup.
this one's working. So go ahead with opening remarks as well. Is that
Yes.
good? Okay, good morning. My name is Alyssa Hundrup. I'm a director in our GAO's healthcare team. And thank you so much for the opportunity to discuss fertility care at VA. My remarks today cover preliminary observations from our ongoing work on this important topic. Access to ART, including IVF, is particularly critical for veterans, especially as research suggests that injuries due to combat, environmental exposures, and trauma are associated with infertility. And infertility rates among veterans have been found to be higher than rates in the general population. Veterans, veterans receive IVF through community providers, but VA medical centers are responsible for determining their eligibility for these services, making care coordination especially important. VA medical centers have interdisciplinary fertility teams comprised of a mix of specialty providers that are responsible for authorizing services in the community. In our ongoing work examining VA's processes, we have identified several challenges in determining eligibility for IVF. In particular, we have heard about difficulties some fertility teams have had in establishing that a veteran's infertility is service-connected. For example, in cases where there is not a known cause of infertility or there are multiple conditions contributing, VA officials told us it can be especially difficult to establish a service connection. We are also finding variation in staff composition and levels of relevant expertise across fertility teams, which may further complicate or delay VA's ability to determine eligibility. For example, some teams may not have gynecological, urological, or other reproductive specialists readily available. Provider and veteran awareness of available services is also critical. Our work has found that VA offers information about fertility services through a variety of means online and at its centers. However, we have seen variation in provider knowledge and understanding of eligibility requirements, potentially leading to delayed fertility care for veterans. Timely action is especially critical given the time sensitivities related to fertility and demand for care in the community, which can result in long wait times. As we continue our work, we're examining how VA can improve its processes for providing IVF services, as well as its efforts to ensure providers and veterans are aware of the important benefits available. Thank you so much. I look forward to today's discussion.
Thank you, Ms. Hundrup. We now have Dr. Alicia Christie. Go ahead.
Ranking Member Takano and members of the committee, thank you so much for including me in today's discussion. My name is Alicia Christie, and I'm a retired Army physician, former VA Deputy Director of Reproductive Health, and a former active duty infertility patient. I'd like to share my story to illustrate the inequities and the gaps in the current policy. I'd like to first ask, if you're willing to give your life in service to this country, what kind of health care do you deserve? Service members are fighting and dying in Iran, a war without a clear objective or an endpoint. Don't they deserve access to health care to build their families? All veterans do not have a VA service-connected condition. I had an infertility evaluation while on active duty. I was diagnosed with endometriosis. I did not seek a service connection for endometriosis, and I do not have any service-connected conditions. The service-connected condition must be the cause of the infertility, and demonstrating a service connection is often not possible. I had very mild endometriosis, and I had unexplained infertility. Even if I was service-connected for endometriosis, it would have been challenging to prove that endometriosis was the sole cause of my infertility. Infertility is a highly complicated condition. The precise cause is often impossible to determine, and 15 to 30% of cases of infertility are unexplained. Declines in fertility caused by aging while in the military will not satisfy the service connection requirement. I dedicated 22 years of my life to the military. I delayed starting a family until I was 33 and had completed my medical training. Fertility declines starting in the early 30s. The VA regulations leave many infertile veterans without access to IVF treatment. My son's father and I were both active duty physicians. Both of us served over 20 years. If I had needed IVF, it would have been a very significant financial hardship, and we may have left the military in order to obtain IVF care. According to the American Society of Reproductive Medicine, infertility is a medical condition. It is defined as the inability to conceive or the need for medical intervention to achieve a pregnancy. IVF services should be provided based on medical need, like other medical conditions. When I retired, I decided to dedicate the rest of my life to advocacy for active duty service members and veterans. I would like to end by asking again, if you're willing to give your life in service to this country, what kind of health care do you deserve? Thank you.
Thank you, Dr. Christie. Before I move to the next witness, I want to acknowledge the arrival of Julia Brownlee, Congresswoman Julia Brownlee, who leads our Health Subcommittee and who's an author of significant legislation on this issue area. Welcome, Congresswoman Brownlee, Woman Brownlee. Congresswoman Dr. Morrison is also another author of an important piece of legislation on this topic. Welcome, Dr. Morrison. Let's move to Ms. Georgette Kerr.
Thank you. Ranking Member Takano and members of the committee, thank you for including the American Society for Reproductive Medicine, ASRM, in today's discussion on fertility care and IVF access for veterans. ASRM is the professional medical society for reproductive medicine. We advance science through research and education, set ethical and clinical standards, and advocate for policies that allow physicians to deliver the highest quality fertility care. Our nearly 8,000 members include physicians, nurses, embryologists, mental health professionals, and legal experts who work every day to help patients build families, including many who have served our country. I am also here today as the proud spouse of a veteran and a two-time IVF mom. I will never forget the moment my husband learned that we would have to pay entirely out of pocket to build our family. His infertility was caused by a genetic condition that was not considered service-connected, so we did not qualify for VA coverage. Despite his service, access to care depended on our ability to pay. ASRM supports policies that expand access to fertility care, protect the physician-patient relationship, and uphold modern standards of care. I would like to highlight a few considerations as the committee works to expand IVF access for veterans. First, ASRM strongly supports Dr. Morrison's Warrior Infertility Act. By recognizing infertility as a presumptive condition under the PACT Act, this legislation acknowledges the link between toxic exposures and reproductive health and helps ensure veterans whose infertility is related to their service can access care through the VA. At the same time, the most equitable solution is to mandate IVF coverage for all veterans. For this reason, ASRM has endorsed Congresswoman Brownlee's Veterans Infertility Treatment Act, which would remove the service-connected disability requirement and ensure that veterans have access to IVF regardless of the cause of infertility. Second, parity should be a guiding principle. Current VA policy allows up to 6 retrievals and 3 embryo transfers, but only for veterans with a service-connected disability. Meanwhile, members of Congress receive unconditional coverage for 3 retrievals and unlimited embryo transfers. Given their sacrifice, America's veterans deserve no less. Third, there is an opportunity to align policy across the military and veteran health systems. Expanding IVF coverage for active duty military families through TRICARE, as envisioned by the Bipartisan IVF for Military Families Act, and coordinating those efforts with VA policy would strengthen the continuum of fertility care from active duty through veteran status. Finally, ASRM urges careful consideration of ideologically driven approaches that could undermine the standard of care by prioritizing religious or moral views over clinical evidence. For example, restorative reproductive medicine, or RRM, repackages elements of standard fertility care, such as diagnostic workups and treatment of underlying conditions, while excluding IVF. Similarly, the concept of, quote, ethical IVF seeks to limit established practices like embryo creation or genetic testing. These restrictions can lower success rates, increase costs, and disproportionately affect veterans who delay family building until after service and for whom IVF may be the only viable path to building a family. Thank you for your leadership on behalf of our nation's veterans. ASRM stands ready to serve as a resource as you continue working to expand IVF access for veteran families like mine.
Thank you for that testimony, Dr. Kerr. Before we move on to Ms. Torres, I want to call on Dr. Ryan. Thank you for getting through the security line, and welcome. So, Dr. Jenny Ryan.
Can everybody hear me okay? Is that good? Great. Again, thanks very much for your patience this morning. Ranking Member Takano and committee members, thank you so much for the opportunity to speak today. I'm a physician and researcher, and I specialize in reproductive endocrinology and infertility. And I'm a professor and clinical medical director at the University of Washington in Seattle. For the past decade, I've had the privilege of caring for veterans both within the VA and in the community. My work focuses on the reproductive health risks faced by those who've served and how to improve the care that they receive. Through this work, I've seen firsthand that veteran men and women face higher risks of infertility, often linked to service-related factors such as military sexual trauma, PTSD, environmental and toxin exposures, and delayed childbearing during military service. Yet many veterans remain unaware that fertility preservation, infertility evaluation, and treatment may be available to them. And those who do seek care often encounter significant structural barriers. One major challenge in the system used to qualify for IVF coverage, which also then includes coverage for non-veteran spouses. The process is unusually complex and difficult to navigate, not only for veterans, but for the physicians and administrators trying to help them. Determining service-connected infertility often depends on documentation from medical care during active duty service that rarely captures the full reproductive health risks associated with military service. Even when cases are properly adjudicated, current policies do not adequately account for common diagnoses such as unexplained infertility, and they exclude age-related infertility, despite the fact that many women veterans spend the peak reproductive years serving their country. At the Puget Sound VA in Seattle, we are fortunate to have an interdisciplinary infertility team that includes a VA-employed reproductive endocrinologist, me, I think I may be the only one right now in the country, gynecologist, a male fertility specialist from urology, and a community care lead with legal expertise. This collaboration helps guide veterans through the system. However, this model is incredibly rare within the VA, and it's probably going away. And many facilities struggle with misunderstandings and misdirection despite their best efforts. In my role directing a clinic that treats veterans in the community at the university, I also see additional barriers. The VA referral and reimbursement process is distinct from nearly every other insurance system fertility practices encounter. Coverage rules are complex, timelines are unpredictable, and policies differ from those used for military coverage, even when administered by the same third-party organization. As a result, fewer and fewer community fertility practices are willing to accept VA referrals. For example, across Alaska, Washington, and Oregon, only 2 practices currently accept fertility referrals from the VA. And only one, our program at the University of Washington, treats medically complex veterans with higher BMI or other medical indications. We provide that care from a single location in Washington State. And while we're honored to serve our veterans, this represents a growing access emergency. So veterans who have served this country should not face unnecessary barriers when seeking to build families or preserve the chance to do so in the future. improving awareness, simplifying eligibility and community care processes, recognizing common infertility diagnoses, and expanding access to fertility preservation and IVF will be important steps towards honoring that commitment. HR 7841 and 220 represent opportunities to do just that. Thanks again so much for the opportunity to be here, and I look forward to any questions.
Thank you, Dr. Ryan. Now, Ms. Carla Torres.
Thank you. Ranking Member Takano and distinguished members of the House Veterans Affairs Committee. My name is Carla Torres, and I'm Senior Counsel at the Center for Reproductive Rights, where we work to ensure that people's reproductive rights are protected such that all people have access to the reproductive health care that they need to build their family. To make this real, all people must have meaningful access to fertility health care that is available, accessible, respectful, and of good quality. Limited information, discriminatory policies, high out-of-pocket costs, and other barriers keep many veterans from accessing the care they need to build the families they want. Although VA recently eliminated some discriminatory restrictions that prevented access to IVF for veterans who are single, unmarried, or in same-sex partnerships, it still requires that a veteran's infertility be service-related. This can be an impossible hurdle to clear, given that service-related infertility is difficult to prove absent a traumatic injury, and that nationally, up to a third of couples are diagnosed with unexplained infertility. Additionally, this narrow IVF provision is not permanently enshrined in law, but rather must be renewed every year. Congress must act to address these gaps in care and to guarantee that VA fulfills its obligation to safeguard the health of the veterans that it serves. Congress must also safeguard veterans against growing attacks on IVF. Since the Supreme Court's Dobbs v. Jackson Women's Health Organization decision overturning Roe v. Wade, and with it decades of precedent protecting the right to abortion, we have seen a stark increase in attacks on IVF at both the state and federal levels. I'll briefly highlight two types of anti-IVF bills. First, bills that would undermine IVF's standard of practice by, for example, limiting the number of eggs that can be fertilized per cycle. And second, bills that purport to, quote, fix women's infertility by treating its, quote, root cause. This so-called restorative reproductive medicine blames and shames women for struggling to become pregnant and then seeks to redefine fertility healthcare to exclude IVF. These and other emerging threats to IVF are generally premised on the legal theory that embryos have rights akin to you and me. This theory, known as fetal or prenatal personhood, may be most familiar to you in the abortion context. It is not a surprise, then, that proponents of anti-IVF bills are borrowing from the anti-abortion playbook. Let's be clear. Attacks on either abortion or IVF are attacks on a person's reproductive autonomy. Abortion care and IVF are not at odds, but rather part of the full spectrum of reproductive health care. Indeed, it is very likely that the same individual may need access to fertility health care, maternal health care, and abortion care in their lifetime. That's why Congress must not only ensure equitable access to IVF for all veterans, but also take action to eliminate the VA's dangerous ban on abortion care. Veterans have risked their lives to protect our rights and freedoms, and to deny theirs, including their ability to access the fertility health care they need to build the families they want, is inexcusable. Thank you, and I look forward to your questions.
Thank you, Ms. Torres. We have veteran advocate Alex Dobhalen joining us virtually. So I'd like to welcome Mr. Dobhalen, is it Ms. Dobhalen, to give her comments, and I guess she's going to join us virtually. There she is.
Thank you, Ranking Member Takano and members
We need
of
to
the
turn up
committee.
the volume.
So
Just 1 second, Ms. Dobhalen.
Sure.
Okay, we're going to try and fix this technical issue. All right.
Can you hear me?
Yes. Go ahead now.
Thank you, Ranking Member Takano and members of the committee. Thank you so much for having me here today. My name is Alex, and I'm an Air Force veteran. My husband and I were both officers on active duty in the Air Force. I'm a military sexual assault survivor, a victim advocate, and a women's and veterans' rights advocate. While on active duty in 2019, my husband and I decided to start our family. For nearly 2 years, nothing happened. In 2020, we finally got pregnant but experienced a miscarriage. Following this, we were able to see a fertility specialist. In 2022, I became pregnant a second time, but subsequently experienced another miscarriage. Immediately, this miscarriage was much worse than the first one, as I was hemorrhaging uncontrollably. The military treatment facility's ER doctor willfully ignored my condition, refused to treat me, or called the on-call OBGYN. He stated he wasn't legally obligated to assist in this situation, and due to his personal beliefs. As a result of not receiving the necessary health care until the very last second by a different doctor, it nearly cost me my life and my fertility. Following that horrific experience, my husband and I took a break from trying to conceive, to mourn our losses and out of fear for my own life. Later that year in 2022, I was also medically retired from service due to mental and physical health conditions I incurred while serving. I enrolled in VA healthcare in 2023, and my husband became a veteran and enrolled in VA healthcare in 2024. Like many other veterans, I was unaware that the VA offered any fertility treatments such as IVF. Most of us, even within my own peer and networking groups, assume most treatments are not covered, similar to the DoD, and the VA is common to tell you what you don't qualify for rather than what you do. I did not become aware of the resources until I met with and spoke with the VA Northern California Infertility Care Coordinators at a women's event in Sacramento. After speaking with her about my husband's and my situation, she recommended the IVF process for us and walked me through how to get started. Sadly, what I have learned through working with her are the immense barriers that exist for veterans to get access to IVF care. Despite having service-connected disabilities, including, but not limited to, unexplained infertility, recurrent pregnancy loss, endometriosis, hyperprolactinemia, ovarian cysts, cervical damage, female sexual arousal disorder, and military sexual trauma and PTSD, I was told I would not qualify for IVF. However, I was told that my husband's service-connected erectile dysfunction would likely qualify rather than my extensive medical conditions. Had I not been married to another veteran that happened to meet a very narrow criteria for IVF through the VA, my hope of having access to this care would have died instantly. The qualification burdens the VA places on members significantly affects our ability to access care that in the civilian world are not debated. Furthermore, as women veterans, it seems we are once again forced to overcome additional scrutiny than our male counterparts in accessing the care that we need. Lastly, despite my husband's and I's dream to have kids, we are now facing concern due to the abortion ban the VA has put into place. While the VA claims that the abortion ban will not affect care for miscarriages, my past experience demonstrates that providers can and do conflate these, and therefore may delay or deny care for miscarriages. Therefore, pursuing IVF care with the VA comes with a very serious risk of costing me my life in the event that I experience pregnancy complications again and seek care at the VA. Women and families like me are in an impossible situation where we have to weigh whether IVF is worth risking our own life. Currently, my husband and I have begun the IVF qualifications process within the VA while still trying to navigate this exact concern. Veterans have served and given their life for this country. At a minimum, we deserve to have the health care we need when we come home. Thank you for your time and look forward to any questions you may have.
Well, thank you so much, Mrs. Dobhalen, for sharing your story with us. I'd like to move to Ms. Kayla Williams.
Sorry, thank you. Good morning, Ranking Member Takano,
Representative Brownlee, and everyone else, thank you so much for being here. I'm going to try not to duplicate the excellent points that have already been made too much. I'll note that the research has shown that VA needs to improve its communications about the IVF benefit, both to providers within the VA system and to veterans themselves. The benefit should be expanded. Care coordination is insufficient. There's poor geographic access to care and additional special needs for SCI, veterans with spinal cord injuries, which I'm sure Ms. Howell will talk about more. And also that the current policy remains discriminatory against certain veterans. I'll also note that the current system, as Dr. Christie mentioned, penalizes women veterans for having been diligent troops, for delaying childbearing in order to serve our nation, which is really disappointing. Finally, I'd like to mention that, in my opinion, it is absolutely unreasonable that some lawmakers would like to impose their religious beliefs upon me and other veterans. I personally don't eat meat, but would never ask members of Congress to impose my ethical beliefs on all troops or all veterans. It's absolutely ridiculous. The Vet Voice Foundation supports both HR 7841 and HR 220 as having excellent ways to move the policy forward and begin the process of expanding the benefit to additional veterans. And I'd like to note on a personal level, I experienced infertility back in 2009 and was unable to successfully navigate the VA system even to get IUI paid for. It's very depressing to hear that there are still challenges in this day and age so far along in getting the full suite of benefits, including IVF, covered for veterans who are eligible, even as we know that the eligibility requirements are too onerous for veterans. Thank you.
Thank you, Ms. Williams. Ms. Naomi Mathis.
Thank you for having this roundtable, and to Kayla's point, I don't want to duplicate any other comments that have been said already, but DAV does represent over 1 million wartime service-disabled veterans and their families, and we believe that veterans who sacrifice their bodies and often their reproductive futures in service to this nation deserve comprehensive, equitable, and coordinated fertility care, which is why we do support legislation such as HR 220, and we thank you for that. VA should not simply be a payer of last resort, but it must also remain the primary coordinator of fertility care for veterans, which would ensure continuity, clinical expertise, and veteran-centered care at every step, which is why we advocate for VA getting that data back, getting the information back from community care providers that offer fertility service to veterans. And we also advocate for them being required to complete veteran-specific fertility training, because as has been said before, veterans deal with unique issues such as toxic exposure, different fertility impacts, including, unfortunately, military sexual trauma. And so I did want to say that veterans, as we've heard, frequently don't know that they're even eligible for IVF. And so outreach must be proactive and not passive. VA should be screening for fertility concerns at every relevant clinical encounter, particularly post-deployment health assessments and toxic exposure screenings under the PACT Act. We are deeply concerned about efforts, whether they be legislative or regulatory or institutional, that seek to restrict or discourage the use of IVF. And I also wanted to say that VA really needs to develop and deploy a standardized national educational protocol for all audiences, whether it be the provider or the family member or the caregiver even, of a veteran. And so to that end, I just wanted to say again, thank you, and we look forward to the discussion.
Thank you, Ms. Mathis. Ms. Julie, is it Howard?
Howell?
Howell.
Howell.
Julie Howell.
Thank you, sir. Ranking Member Takano, members of the committee, thank you for the opportunity to participate in today's discussion. PVA has long been a champion of expanding access to IVF, and we're proud of the work we have done to improve access to health care for our nation's disabled veterans, particularly those with catastrophic injuries and disabilities. We appreciate the legislation that has been introduced over the years to include Representative Brownlee's Veterans Infertility Treatment Act and Representative Morrison's the Warrior Infertility Act. PVA will stand behind any legislation that increases access to IVF, removes administrative burdens or barriers, and prevents unnecessary harms to veterans. I've been working to pass legislation expanding access to IVF since I started at PVA about 4.5 years ago, and we haven't really made any real progress. PVA is lucky enough to host an IVF working group that contains many of the folks that are around the table today. We welcome fertility organizations, veteran organizations, providers, and other stakeholders who fight for the expansion to ART and IVF for veterans and service members. We work as a coalition to lobby Congress to support existing legislation as well as expanding access through the NDAA with varying levels of success. We've recently been having discussions about how do we find a way to expand access outside of our traditional pathways. This may look like narrower victories like Rep. Morrison's bill, recognizing that veterans with a toxic exposure service-connected disability may likely also experience infertility. This is true for veterans, especially for women veterans who may be MST survivors, veterans who live with PTSD, anxiety, or depression, or a host of other very blatant service-connected disabilities. I think one thing that I always stress is that it seems to be inequitable when a male veteran has a distinct service-connected disability. So for example, we have a PVA member who lives with multiple sclerosis, or MS. Because of the medication that he is on for that primary service-connected disability, which was presumptive, he experiences infertility due to his medications. So he was granted secondary infertility, or secondary service-connected infertility, which allowed him to access IVF services. It just so happens this gentleman lives in Oklahoma where there is one fertility clinic. So after years of fighting, he and his wife were able to access IVF, but then there was all kinds of administrative problems with the clinic where VA said that his treatment was covered, but not the treatment for his spouse. So they would have been on the hook for thousands of dollars for the infertility medication that was necessary for this to be successful. I'm not gonna come into this conversation and pretend like any of this is easy or that there's a simple solution to any of it. Clearly that is not the case. But just know that most of the folks around this table, PVA and myself, we're happy to work with all of you and anyone else who wants to expand access, particularly for catastrophically injured veterans, and we look forward to doing the work to make sure that some of this stuff gets across the finish line. Thank you.
Well, thank you, Ms. Howard. That was very insightful, enlightening. Ms. Maureen Elias.
Good morning, sir. It's good to see you again.
Good seeing you
Dr.
again.
Morrison, Ms. Brownlee, great to see you as well. Thank you so much for making time to be with us today for this conversation. I know how precious your time is. And thank you for the opportunity for Wounded Warrior Project to share our perspective on VA's provision of IVF and ART services. Veterans face higher rates of infertility than civilians. We know this. According to a 2023 VA study, OEF women veterans had a higher infertility rate than their male counterparts, and our own 2025 Wounded Warrior survey reflects the same trend. 13.5% of our women reported difficulty conceiving, which is nearly double the rate of our male warriors who reported the same. An NIH-supported study also found that women veterans are more likely to seek infertility care, which signals growing demand as the number of women veterans increases. Our benefits team has helped 35 warriors obtain service connection for infertility-related conditions, and over 2,200 warriors for SMC for loss of use of a creative organ. This is over the lifetime of our benefits service, which I think demonstrates how hard it can be to get service connection for infertility-related conditions. Warriors reported that when they tried to access family planning for fertility services, they faced three main barriers: trouble getting timely appointments, difficulty reaching clinics or pharmacies, and unaffordable costs. Many also describe poor communication or administrative delays and confusion when navigating between VA, TRICARE, and civilian administrations. One warrior, as Ms. Hundrup talked about earlier, the confusion, it equals loss, right? It equals cost. One of our warriors reported that they spent 5 years being misdirected, paid $30,000 out of pocket, and by the time they were able to get what they needed, they had aged out of the ability to apply for any grants from nonprofits to help them conceive. Meanwhile, federal employees and many private sector workers have significantly better access to IVF. Federal health plans cover artificial insemination and IVF-related medications for 3 cycles, and several national plans offer $25,000 in IVF benefits. Nearly half of large employers offer IVF, and 64% of those don't even require an infertility diagnosis. Sorry, I lost my place. Addressing these inequities requires practical steps that remove avoidable barriers. Some of our warriors have also reported being denied services based on marital status or sexual orientation. These inequities, combined with inconsistent guidance and complex eligibility rules, create system-level barriers that prevent timely, appropriate reproductive care, which many of the women at this table have spoken about already. One simple improvement Congress can make is authorizing VA to cover cryopreservation transportation costs. As Julie talked, sometimes it's going to be little steps to get us to the finish line. This is one of those little steps. Title 38 does not prohibit this, only VA's directive does. The fix would especially help a population of women veterans that rarely gets named. Women veterans who are military spouses. Their frequent relocations disrupt continuity of care and complicate eligibility. Just to give you an idea of how many women we're talking about, in 2021, there were about 159,000 military spouses who also qualified as veterans per VA standards. But yet, no one is even tracking their outcomes. We don't even have something to call this population. Finally, as so many others at this table have, I want to acknowledge biology. Women's fertility declines sharply after age 35, while men remain fertile much longer. We often delay childbearing due to deployment schedules and career demands. By the time when they separate and are ready to seek VA care, their fertility window has already narrowed, an issue many male veterans do not face in the same way. VA policy needs to reflect this reality. Women veterans face a higher biological and structural risk of age-related infertility, and eligibility rules need to account for that. Thank you so much, and I look forward to working on you with solutions.
Wow. Well, since you left my staff, Maureen, you haven't lost your effectiveness. That's great. Ms. Jennifer Ross.
Thank you. Ranking Member Takano, members of the committee, thank you for this opportunity to speak on this very important topic. My name is Jennifer Ross. I'm the Manager of Federal Policy for Iraq and Afghanistan Veterans of America. I'm also a GWAT veteran and an Air Force retiree. Peer-reviewed research shows that 40 to 50% of my generation of post-9/11 veterans meets the clinical definition of infertility, 2 to 3 times the rate seen in the general U.S. population. These elevated rates are strongly associated with military-specific exposures and the physical and psychological demands of military service. Yet awareness and navigating the VA system remains a significant barrier to those even who have experience with the VA healthcare system. Despite these higher risks, military families have the least access to modern fertility care of any major insured population in the United States. While we're glad to see that the VA has recently expanded eligibility, the service connection requirement still excludes the vast majority of veterans with infertility. Veterans whose reproductive harm stems from cumulative toxic exposure, not a single traumatic injury, are left without a pathway to care. Meanwhile, nearly half of U.S. employer health plans, and as Ms. Kerr mentioned, even Congress, cover IVF care, and among large employers, that number reaches almost 70%. Veterans drain savings, they take on debt, or they abandon hopes of having children altogether. Many face long waits and complex referral processes, and that varies dramatically even by location. Restricted state-level trends threaten to shrink the already limited network of community IVF providers willing to even treat veterans. Congress has clear levers to fix this. Remove or modify service connection requirement, authorize IVF-related care involving gestational carriers, and protect IVF access from restrictive state laws that bring VA fertility care in line with modern medical standards. Veterans did not choose their exposures, but they freely gave their critical years of life to serve. These service members should not have to fight another battle to build the families they dreamed of while serving their country. Thank you, and I look forward to questions.
Thank you, Ms. Ross. Ms. Sharon Arana.
Good morning, Ranking Member Takano and distinguished members of the committee. I am Sharon Arana, a recently retired Air Force Lieutenant Colonel, and I'm here on behalf of Minority Veterans of America. MVA appreciates the opportunity to participate in this roundtable. Our organization works to advance equity and belonging for historically underserved veterans, including racial and ethnic minorities, women, LGBTQ+ veterans, and non-religious minorities. The demographics of the veteran population are changing rapidly. We know that women veterans are the fastest growing segment of the veteran community. LGBTQ+ veterans also represent a significant portion of the post-9/11 generation. The shift in demographics can be seen in the types of services needed by our veterans. For example, the number of pregnancies among veterans using VA care increased more than 80% between 2014 and 2022. Demand for reproductive care in VA is increasing as a population of women and LGBTQ+ veterans grows. Yet many federal veteran programs were designed decades ago for a population that was overwhelmingly white, male, and heterosexual. As a result, structural gaps persist across the entire spectrum of healthcare, and these gaps are not accidental. They reflect policies and systems that have not kept pace with the changing realities of military service and the veteran population. Addressing these disparities requires deliberate policy interventions that recognize the evolving demographics and experiences of today's veterans. MVA supports expanding fertility care for our veteran community to ensure continuity of care, especially after our service members hang up their uniforms. This includes comprehensive fertility care for all, to include IVF, abortion, surrogacy, and adoption support, along with counseling and support services, and, most importantly, the elimination of the service connection clause. Infertility is often complex and multifaceted. Veterans may have been exposed to toxic substances, experienced combat injuries, or endured years of operational stress that affect reproductive health in many ways that are difficult to prove through our traditional disability claims framework. As a result, many veterans who need fertility care are simply unable to access it through VA. Veterans who sacrifice their health in service to this country should not face additional barriers when they try to build families. Expanding equitable access to reproductive care through VA is not only a healthcare issue, but also a matter of fairness, dignity, and honoring that service. I thank you again for your time, and we welcome discussion.
Thank you, Ms. Arana. Ms. Rita Graham.
Good morning, Ranking Member Takano and distinguished members of the committee. Thank you for both the opportunity to speak and for even getting us to this point, specifically the March 2024 reforms to get us here. My name is Rita Graham. I'm the Director of Government Relations at the Service Women's Action Network, or SWAN. I'm also an Army veteran. And as one of the first women integrated into ground combat units, I went months without access to a bathroom because, as my commander told me, the ratio was not in my favor. Due to operational constraints that my male counterparts did not face, I developed pelvic floor dysfunction because there was simply nowhere for me to urinate, both in garrison and operationally. 1 in 3 civilian women experience pelvic floor dysfunction, and without data, we don't know how many women veterans do, but we can almost certainly assume that it's a lot higher. This condition has affected nearly every aspect of both my physical and mental health. Yet, it was not determined to be service-connected because there is quite literally no VA diagnostic code for pelvic floor dysfunction, despite its well-established link to reproductive health complications and infertility. I separated the military 2 years ago. I'm still learning the impacts of my burn pit exposure, my daily handling of ordnance, and my overall blast exposures. But what I do know is that I have been diagnosed with pelvic floor dysfunction, and the VA won't help me. So now, as I start planning a family with my spouse, I have to explain to them that without my VA service connection, we might have to pay $30,000 or more in out-of-pocket costs for fertility treatment because I didn't have a bathroom while serving my country. This story is not unique. Women veterans experience infertility at rates twice as the rate of civilian women's, and a 2020 internal SWAN study found that it could be as high as 4 times higher, with BIPOC communities disproportionately represented. Yet access to fertility care through the VA remains limited, as mentioned today. The burden of proof that veterans have is extremely difficult, particularly without a clear physical trauma. The first comprehensive study on VA infertility diagnoses was conducted in December 2021 under the Deborah Sampson Act. That fact alone highlights how little we understand about women's health, reproductive issues. And that's why today, SWAN strongly supports this legislation. Ranking Member Brownlee's Veterans Infertility Treatment Act codifies recent VA policy changes into law, which so importantly ensures the access is not dependent on shifting administrations. Dr. Morrison's Warrior Infertility Act would recognize infertility as a presumptive condition for toxic exposure under the PACT Act, eliminating the high burden of proof currently required to establish service connection, as both me and many other women veterans have experienced. At a time when women veterans are already facing new restrictions on reproductive health care, including December's quiet rollback of abortion counseling and services in the case of rape and/or incest, it is particularly important that the VA ensures the ability to build a family is not blocked by outdated policies, incomplete research, and unnecessary bureaucratic barriers. As one of our community members put it, infertility treatment is too often treated as an elective procedure rather than the disease that it is. Fertility healthcare is not a luxury. It is part of a comprehensive healthcare system, and one that the VA is still failing to provide equitably to women veterans. No woman and no veteran should have to pay $30,000 for the family they've dreamed of having because of our service to our country. Thank you, and a huge thank you to our coalition allies that have helped to get us to this point, and I welcome the discussion.
Thank you for that, Ms. Graham. Thank you for the testimony from everybody here today and who are also appearing virtually. We're going to move on now to the question and discussion section of the roundtable. I'm going to direct some of these questions to specific people and ask you to answer these questions first, but if anyone has thoughts they'd like to share, please just put your nameplate on its side horizontally, and we'll go around to everyone in order. And of course, my congressional colleagues, jump in. My first question is for any of the VSOs or for Alex, who's appearing virtually, our veteran advocate who's appearing virtually. My first question is, why is IVF access especially important for veterans, including disabled and paralyzed veterans? What considerations does VA need to keep in mind for veterans in these populations when considering IVF eligibility and access? So any of the VSOs or Alex would like to weigh in on that question. Go ahead, Maureen.
Thank you. That's a great question. And I think one population that we tend to not think about when we're talking about infertility is veterans with TBI, traumatic brain injury. The challenges that every single person at this table has described in navigating the complications of the system, the providers not knowing what's being provided, and the veterans not even knowing what's available. Now imagine trying to navigate that on top of dealing with a TBI. So I think, expansion of services is really important, but VA needs to focus too on getting this right, and I don't think we're there yet. So, even with PTSD, sometimes navigating complex systems can be very frustrating. You can have memory problems or other issues that make just navigating anything that's complex to the point where you're like, I'm done, I give up, I don't want to do this, right? And so I think, I'm sure Julie's going to talk a little bit more about the SCI population in particular, but I think for Wounded Warrior Project, TBI is the signature injury of OEF, OIF, and so for warriors navigating infertility and ART services through VA, ensuring that they have special support so that they can navigate it successfully would be really valuable. Thank you.
Well, thank you. Great. Julie, do you have a response as well?
Sure. Thank you for the question. Pardon my initial confusion. I was kind of like, wait, what's the question? What's the crux of the question here? Why now? Why ever? I think from the lens of PVA, and thanks to my counterpart, Jen, over here, I think it's important to recognize that the healthcare system often infantilizes people with disabilities, especially people with severe disabilities. It's not really up to a medical provider or someone who's, just your primary care provider. It's not up to them to make the judgment or value call on whether or not a person is capable of having a child. With advancement in durable medical equipment, with accessibility, with, even something as simple as an accessible changing table. Like these things that exist, previous barriers that we have encountered historically are mitigated in a way that open up avenues for people with disabilities to become parents. Just because someone has suffered an injury or an illness, that does not mean that they are no longer capable of having a family. And I think as, awareness grows around medical gaslighting, particularly for women and the complexities that they face with their own healthcare, it seems that sort of the reproductive system is maybe a mystery to most folks unless they're experts. I think for VA, its core mission is to care for service-connected disabled veterans, and that includes women. And infertility, as everyone has cited all of these studies, time and time again, they are failing at that mission. And there's barrier after barrier after barrier, whether it be bureaucratic or medical or access or any other thing. Just because you cannot produce a piece of paper that says, this is what I'm owed, this is what I'm due, that does a disservice to these folks. And as Dr. Christie mentioned in her opening remarks, very rarely do people join the military just so they can get awesome VA healthcare. That's not really what calls us to serve, I joined the Army on my 17th birthday. I was overwhelmingly patriotic. I have thoughts about that now, but I didn't join for VA healthcare. The world told me that I was now eligible for VA healthcare. And I think that as long as we can get back to VA being very successful at its core mission, which is delivering healthcare and benefits to disabled veterans, it is critical to remember that that's every aspect of this veteran's life. If you're 100% service connected and you have access to the full range of the medical benefits package, IVF is the only thing that you are not authorized for. Out of everything that VA does, that's the one thing that you need extra proof for. And we've already noted numerous times that that becomes exponentially more difficult for a woman veteran than a male veteran. So I'm just gonna leave it at that.
I'm going to call on Alex virtually, then Kayla, and then Jen, and then my colleagues. I'll ask if you have any questions for the group. So Alex, you want to respond?
Yes, thank you, Ranking Member Takano. I think this is a very obvious issue, but for a multitude of reasons that are captured across a broad spectrum. Access to IVF is extremely important for veterans and active duty military members. We face additional challenges that our civilian counterparts don't face, whether that be because of our rigorous duty schedules, our constant requirement for deployment, PD-wise, often like in my case of being mill to mill, being separated from our spouses. And so a lot of times, or the due to mission requirements, or especially in women's situation and desire to advance your career, as many people have mentioned, the ability to have kids within the military is getting delayed further and further. We simply, between burn pit exposures, toxic chemicals, operational requirements, we just face a lot more intricacies than a lot of times our civilian counterparts. And so being able to have access to these resources are so important. Like in my situation, my husband and I have been trying for the better part of a decade to have kids in our marriage, within our marriage. And due to different circumstances, mostly involving the military and service-connected health conditions, we have not been able to do so. But having access to this IVF is crucial. But as many people have stated, the awareness of it just doesn't exist prolifically. And so being able to connect our veterans to these resources, facing the unique needs that they do, is crucial. Also, oftentimes are facing disabilities that maybe our civilian counterparts aren't as frequently experiencing. and are harder to capture. And as so many have said, it makes it harder to connect that specific experience and condition directly to infertility, even though the science supports it. And so I think that access to IVF without the service connection requirement is so crucial.
Thank you, Alex. I'd like to turn to Kayla, then Jen.
Thank you so much. I think everyone's opening remarks gave a lot of fantastic examples of why it's so important, and I wanted to add another element, which is that we know that there is an increased rate of cancer caused by toxic exposures, and as veterans seek oncology care, it's really critical that the education component that we've also all brought up include within the Department of Veterans Affairs, ensuring that oncologists are aware that this is, that IVF can be a covered benefit so that they can have this conversation early before treatment starts to preserve the decision space for veterans into the future. And we've seen from some of the research that within VA, much of the expertise on IVF as a covered benefit and how to coordinate the care and navigate it is housed within the women's clinics, which is a bit mysterious given that this is not an issue that is restricted to women. And so it's really critical that we ensure that the information be adequately and fully disseminated within the entire VA system, especially in specific departments like oncology, like SCA.
Thank you. Jen.
Yeah, and thank you. And just to kind of piggyback off of what Kayla mentioned, I also wanted to highlight, so the post-9/11 generation is one of the most diverse out there. About 19% of the total service is now women. In that, about 45% of that 19% are dual military service members with both the husband and wife serving in the military. So in comparison, that's about 1 in 5 women service members to 1 in 25 of their male counterparts. So while the infertility does often house in women's clinics, this isn't an issue that just affects women. It affects our dual military service members and then detracts from the ability of these dual service couples to remain in service because they do lack the care on both sides for the husband and the wife to treat infertility issues. And as we continue to see a growing population of women in the military choosing to serve, choosing to stand up, this is something that we need to modernize within our own healthcare to ensure that we're attracting all military members and all citizens wanting to serve their country.
Thank you. Ms. Brownlee or Dr. Morrison, any questions or comments?
I defer.
Thank you all for being here. This is a great roundtable. Thank you for convening it, Mr. Chairman. And I have a lot of questions, but I will try to stick with one to start out. So I just wanted to go back to age-related infertility. And does anybody know what the percentage of age-related infertility is over the entire infertility diagnoses? Is it more common? I'm thinking about, I think someone in their comments talked about women being punished for serving in some sense because they have put off pregnancy and that kind of thing, or having a family due to their service, and wondering if the age-related infertility is more common with women veterans than not.
Thanks for that question. It's like many things in women's fertility, it's complicated because usually when we make a diagnosis, it's rare that we have one association with infertility. Half of the time there's aspects of male and female infertility. If you have a heterosexual couple, we often, will say this person has ovulatory dysfunction and advanced reproductive age. so anything over 38 we consider advanced reproductive age. That may affect somebody's egg quality more than others, so it's a bit hard to nail that down. I would say that we now know that there are more women in their 40s having pregnancies than women in their teens. So it's an increasing issue, across civilian and military populations, but it is specifically, as been stated, an issue for veterans because of issues with deployment and in service, and then people, waiting to expand or to build their families until after service. So, in my own practice, we see half of our patients are over 40. And so it's definitely a big issue, but I can't give you, an exact percentage.
Dr. Christie.
Over the age of 35, about a third of women will have difficulty getting pregnant. By the age of 45, the only option is donated eggs. So you could get a rough estimate of what the impact is by knowing the demographics of women veterans. And Dr. Jody Caton has published, and also Dr. Ryan, in the medical literature about the demographics of women veterans, and so you can get some estimate from that.
Dr. Morrison?
Thank you, Mr. Chair. Thank you all so much for joining this morning. Your stories are powerful and devastating. And I feel so angry right now that it's, as I practiced as an OBGYN for more than 20 years, so I've taken care of numerous women who have struggled with fertility. And I think it's worth reminding people that the journey that patients go through is arduous and long. You're not technically considered infertile minus a devastating injury until you've tried for 12 months, right? And at that point, then maybe you begin the workup to try to figure out what's going on. In that case, then is it ovulatory dysfunction? Is it a mechanical blockage? People have to undergo a procedure to determine that. Or is it male factor? So semen analysis. Then after that, and those are all unpleasant and uncomfortable procedures at a time when you already are going through something that's really hard. And then from there, sometimes you'll try ovulation induction agents with IUI, plus minus IUI. You guys nodding heads, like it's a whole thing. IVF is, for many, much farther down the road. And the expression that I think you used, Ms. Williams, was really struck me, that women are being penalized for being diligent troops by delaying childbearing to serve. It's stunning to me that women veterans aren't given an absolute gold plate treatment when they separate from their service. What we should be doing is thanking everyone. It's particularly galling to me at a time when we have an administration who talks a lot about wanting women to have babies. They're pro-natalist, right? So to deny access both to fertility treatment and to comprehensive reproductive health care, you cannot separate different aspects of reproductive health care from each other. And of course, I'm in part referring to abortion access. I could go on, but I won't. I'm really grateful to all of you. I do think that Ms., I want to pronounce your name right. Dobheim, is that right? Dobheim, Ms. Dobheim. Your story encapsulates all of this. I mean, you've been through so many different insults and tragedies and challenges, both through your service and after. And your story speaks to why we should not be making healthcare policy based on ideological opinions or beliefs that should not be applied to all people. So it strikes me that a lot of what we're talking about comes down to awareness and education. We've talked about how VA could do a better job of, both at separation and during transition to make sure that we're screening. That's been something in our field that has come up lately. Like, start having that conversation earlier with women so that they're thinking about it too. It has to be done well and appropriately, but it's an important conversation. It's an important part of the lifespan of women. That's one thing. And also, I'm wondering if awareness and education in the general public, at VA, among service members, and arguably most importantly among lawmakers. So I'm just wondering if any of you have ideas about how to approach that. Your stories are unbelievably powerful. I know I've served in the Minnesota legislature, state legislature, and when I was elected, I was like, cool, I'm gonna bring my data and my charts and my facts, and we're gonna make good policy together.
Done.
And that's not how it works. So stories are unbelievably compelling, and they do change hearts and minds. So I think that's part of it. But I'm just wondering if any of you have other thoughts. And thank you again from the bottom of my heart for being here and sharing your stories.
So, Dr. Morrison, I think you crystallized this issue so succinctly when you said that our women veterans, or perhaps our veterans generally, but women veterans in particular, because they've been good troopers, deserve gold-plated benefits. That was very poignant and very succinct, and it's very moving. A number of people have been inspired to respond to your question and comments, but I want to go to Alex, who's raised her hand while you were speaking, and then we'll go in order to the folks who've raised their cards here. So Alex, you have a response.
Thank you, Ranking Member Chicano. Also, thank you, Dr. Morrison, for your acknowledgement. I appreciate that. I actually wanted to address something that you had said, Dr. Morrison, and actually a few other people have highlighted. This whole concept of penalized for being diligent troops. A lot of you are interpreting this as, yes, we as women are passionate about what we do, we're proud to serve, and we're working really hard to serve our country, and oftentimes putting our careers first, and that sometimes penalizes us because we seek the families we desire to have later in life. But there's another way to look at how this concept of being penalized for being diligent troops. Another thing that it may not be tracking is a lot of times there is a lot of stigma in seeking healthcare while in the military. If you go to doctor's appointments for various conditions and you miss work or out of the office, there's that high stigma for getting treatment for things that would be service connected during time in service. And the reason why this becomes a big deal is then when you get out and you are a veteran, those things like your burn pit exposures, your endometriosis, or a lot of things that may be service connected for infertility are no longer documented. So this is just yet another way. And there oftentimes is, I will say, a lot of extra pressure on women to perform and feel the need to justify the quality of our service while are in service, especially under the current administration. So a lot of times we don't seek the care that we need. And then when we become veterans, this is yet another way in which we're being penalized for being a diligent troop, because we struggle to get service connection for things that existed while in the military, but there may not be as many records for it because of the stigma to seek help or treatment while in the military.
Thank you for that, Alex. I appreciate that. So next, Georgette.
Thank you for the question. I just wanted to briefly touch on ASRM's experience on the policymaker side and educating policymakers. I think all of us that are up here every day, we experience this. Every staffer, every member of Congress you talk to either has a personal connection to infertility or knows someone who does. However, there is a lot of lacking knowledge on, the benefits that congressional staff, members of Congress have, as well as the populations who we serve. So ASRM noticed this, pretty early on, and 2 years ago, when the DC mandate for IVF insurance went into effect, we started to host an annual sort of briefing. We normally timed it around open enrollment for congressional staff. One, to kind of do Fertility 101 with them so that they sort of understood some of the challenges that we're talking about today, not just common diagnoses, but things like age-related infertility. And two, it was unbelievable to know how many congressional staffers, including staff who work on these issues, did not know they had access to these benefits. And so we sort of drew people in that way. We said, come learn about your benefits, but stay for the policy. And, you could not imagine, these staffers learning that they had access to this coverage and then telling them that veterans did not. We were picking jaws up off the floor. And so I think it's that kind of lack of awareness, but sort of connecting it to members of Congress, congressional staff up here, their personal journey with these issues. I think we can make a lot of momentum, on that way in a policy sense. And so ASRM would welcome the chance to coordinate with this committee, with your offices, because this has now become such a popular annual sort of event that we do up here on the Hill, to make sure that we are covering this particular population and getting buy-in, from those staff who do feel these issues very, very deeply and intimately.
Thank you, Georgette. I can imagine an email that comes from the Veterans Committee staff, one, telling all the member offices that there's this event, open enrollment, but also we can put another little jab in there saying, and do you know you have access to fertility treatments, but our veterans do not? Could be an interesting way to build a coalition here. Julie.
Thank you, sir. Representative Morrison, just to your point on education, it's perfect that Georgette went before me because recently ASRM partnered with Resolve, I believe, to hold a briefing on infertility and IVF access at the Capitol Visitor Center that was crashed by advocates for restorative reproductive medicine. I think when it comes to education around any issue, and this might get me in a little bit of hot water, but I think members and their staff need to recognize that just because it's on a shiny piece of paper doesn't mean it's the truth. There is a lot of money being funded or being pumped into these sort of counter discussion topics, but because they're wrapped in a pretty package, we think it's legitimate. And I think we've gone through decades now of being told that women haven't done enough or been enough, or they ate too much processed meat, or they shouldn't have X, Y, or Z, and that is how come they struggle. And that's literally just going back 30 years. In my personal opinion, that's what restorative reproductive medicine is. These things can work in tandem with one another, but RRM wants to cut out where the science is. And I have no doubt in my mind that they have very pretty handouts that they leave in the offices. And I think providers, we're really lucky to have so many medical providers on HVAC right now. It's actually remarkable. You guys are all very busy. But I think also if, let's get the providers together to educate your counterparts to just because it's on a shiny piece of paper with a picture that probably came from Getty Image, doesn't mean it's real. And I think with PVA in particular, we struggle around healthcare bills because we have to do a lot of educating. And when you have young staff who maybe don't have that lived and shared experience in high turnover, I think it has to come from both directions, right? It has to come from the top and the bottom. Your staffs idolize you. Well, they're really excited to work for you. How about that? We all get, it's all shiny and it's wow, and it's, oh, I'm on the Hill. And I get it, it's exciting. They're gonna follow your lead. We can come up with our coalitions and have our meetings and ask, but I think it's gonna take a lot more than just us in this moment to shift the needle on this.
Thank you for enlarging my self-awareness about staff. Watch out. Sharon.
Thank you for that question. So I think for us, what I see is, the lack of transparency is the weapon. and it's that opaqueness that is used in order to increase barriers to access. The more you keep folks uninformed and ignorant about what is happening. So in doing research for this panel, one of the things that we were surprised to find out was that most veterans report that, like, for example, fertility care is never discussed during routine VA appointments. So while we talk about on staff and what could happen here as far as pushing policy, but when we talk about from a grassroots, down to the folks who are being affected and the secondary, tertiary effects of the people around them as well, those being affected, when we start educating folks, that is when, you get the rage, you get the ire, because they don't know that things like we were talking about highlighting the lack of parity between coverage with active duty TRICARE members and federal employees, and the coverage that those members get versus our veterans. So as a recently retired military member, and I'm now navigating the VA system, I'm still learning, and that's someone who has been in this environment and in this system for doing advocacy work while in uniform for the better part of a decade, and it's even now I am still learning. So what happens when it's the folks who haven't done this research? What happens when it's, the airman who is being medically retired and still gets services, and they are not being told what it is that they can actually have access to? But I think that is the biggest crutch of it, is the education piece, the research as well. There is such a lack of research and just data points behind the veteran population and how we are being affected, whether it's women veterans and infertility, LGBTQ plus environment as well, like that community, and how infertility rates are affecting them. But these are a continual problem that we kind of need education for, and as well as research, so that we can start backing this up. Thank you.
Thank you, Sharon. I'm going to continue on but I just want to make sure I acknowledge the presence of other members. I should have introduced Dr. Conaway, who is a member of our committee. Dr. Conaway. So one of 3 doctors that we have on the Veterans Affairs Democratic side of the aisle. And I do echo the sentiment that I appreciate that we actually have medical providers who understand this, and it was amazing to listen to the expertise of Dr. Morrison. And we have Representative Underwood, who someday may come back to my committee, who has experience as a nurse. So Dr. Underwood, welcome. You come in the middle of an amazing discussion. Dr. Christie.
Thank you again for your support on this important issue. When I was at the VA, I had the privilege of being the VA liaison to the American College of Obstetricians and Gynecologists. And that committee published in January 2025 a committee opinion that summarized the reproductive health challenges of active duty service women and women veterans, and I'm happy to provide that document, and also made recommendations to practicing obstetricians and gynecologists about how they can best support their active duty and veteran patients. Also, American Society of Reproductive Medicine sponsored a webinar that Dr. Ryan and I participated in, where we summarized the gaps and inequities in care for fertility patients in VA and DOD. And lastly, what I always tell my patients, I'm a Red Cross volunteer physician at Walter Reed, and I see infertility patients, is knowledge is power, and in order to self-advocate, you need to self-educate. And the American College of Obstetricians and Gynecologists has a wonderful patient education site, Women's Health. And I give my patients that QR code so they can educate themselves about their medical issues. ASRM also has an excellent site, reproductivefacts.org, and I give that QR code to my patients so they can educate themselves as well. So I think those are resources that can be very helpful. And to the issue of restorative reproductive medicine, ACOG published a really great issue brief on that topic, which outlined the potential harms, which include delays in effective treatment, limited access to proven medical care, and unnecessary surgical procedures. Thank you.
Thank you, Dr. Christie. I look forward to reading that briefing. Rita, I'm sorry we skipped you. Go ahead.
Thank you. I just want to highlight the call for research as well. That, and I won't speak for Alex, but every time we as veterans share these really intimate stories, it takes a piece out of us. And I'm proud that I have the ability to share this story and that I have this platform, and I do it for the soldiers that will never have the ability to do this. But we need research to back this up. I didn't even know I was one of the first ground combat women until I was in graduate school studying it as a research fellow. When we're these trailblazers, as literally every single woman in this room is, but when we're on these front lines, we don't know that what we're doing is special because we're doing our job and we just want to accomplish the mission. So the research is so important because we need to know, are there other people like me that have this condition? Is this just me? Am I alone? Are there even resources for this? And the fact that the VA doesn't have basic establishments of care that the World Health Organization has listed, that the American Society for Reproductive Health Medicine, these basic conditions that are established by governing bodies that know how to do this. The VA can't even establish basic care and basic practices for it, and especially when it comes to community care as well. Senator Duckworth has already gone on record with her issues when she tried to get IVF and was denied because her provider had religious exemptions. There's just such basic lacking elements of care that without such research, we can't prove that this is a widespread issue. My story is important, Alex's story is important, every woman's here story is incredibly important, and I'll be screaming, I'm like, oh my gosh, I could soapbox forever the stories I've got that would drop jaws, but we need the research to back it up just as much, and the VA just hasn't done it, and that's what we need moving forward. Thank you.
Acknowledging that this is not just attributable to one, this is an issue for one gender over the other, but we know there's particular issues related to the fertility of women veterans. I'm really aggrieved that we haven't had the leadership that was provided in the past by Julia Brownlee over the Women's Veterans Task Force. We're missing that particular entity, but with nearly 20% of the veteran population being women, we haven't moved aggressively and as fast as we need to get the VA to respond as an institution. And Rita, your comments, I think, go to that. And when the gavels come back, we can be assured that we're going to establish that commission, that task force again. So I want to go to Jen.
Thank you. And I just wanted to add, again, echoing the call for research. In 2022, the American Journal of Obstetrics and Gynecology actually did a survey, a national sample of about 1,200 women and 1,400 male veterans. Almost 50% of the women and 52% of the men had met the definition of infertility. So again, while women are disproportionately affected, this is something that all veterans are facing, and the need for research across the full spectrum that is tied to toxic exposure causes for infertility. These are all things that need to be examined because out of that group, only about 12% reported a formal infertility diagnosis. So this is an issue that's affecting the service as a whole and needs to be researched holistically for all of the veteran population, especially those with significantly higher exposure to toxic exposure. Thank you.
Thank you. I wanted to pick up on the comment that was made by Alex virtually, which is around the high level of stigma that surrounds not just infertility, but needing access to fertility health care and choosing or being able to build your family using fertility health care. It can be very socially isolating, and it can be very isolating if you were in a partnership as well. And in particular for people in the Black, Indigenous, and other people of color communities. And I want to note that roundtables like this and bills like yours really help to start conversations that are otherwise not being started and not being had. And so I think part of it is sharing our personal stories, or really compelling personal stories, giving platforms to people to speak about their expertise and their personal experiences goes a really long way, as do the many resources that have already been called out. The Center in 2020 published an issue brief along with Service Women's Alliance Network to essentially talk about all of the barriers that veterans and service members are facing and to make recommendations on how to address those barriers. And to the point about research, I think it's really critical that in order to develop policies and laws to address an issue, we understand what the issue is, who is disproportionately impacted, what are the barriers to care, and how can we meet that unmet need. The last thing that I'll say in order to talk about education is we need to be talking about infertility and access to fertility healthcare, not just in this room, but in rooms where we're talking about access to contraception, access to abortion, access to maternal health care, access to mental health care, because this is such a heavy emotional and mental burden for people who struggle with infertility. And so I think finding those intersections and having more robust conversations that brings more people in, conversations around LGBTQ populations also, like we need to be people with disabilities, we need to be converging these themes and these issues into more streamlined conversations because, as I mentioned in my remarks, individuals of all shapes and sizes experience infertility, and we really need to having conversations that robustly address their experience. Thank you.
I'm going to call on Dr. Ryan, and then I'm going to ask Rep. Underwood and Rep. Conaway if they have any questions. So Dr. Ryan, go ahead.
Thank you. This is just such an amazing conversation. I wanted to bring up a few issues. I think in the community, in the healthcare provider community, it's important that, and ACOG brought this up in their practice committee document, it's important that all healthcare providers out there who are seeing reproductive age individuals are asking them about their military service. And I think that points to the question that was brought up earlier, and the point being that, I mean, we should all be practicing trauma-informed care, but that's a particularly important thing when we're working with veterans. And that in our practice, because again, we're such a practice that's so enriched with veterans, which I think 16% of our infertility population is a veteran population. So we have a real focus on trauma-informed care. It's been a good reason for, a good impetus for us to really re-engage in those conversations every year and make sure of that. But I think not only does that help providers kind of understand their population, but also understands this higher risk in this population. And also they appreciate, I hope, the real privilege of taking care of veterans. And I think that has to be communicated also to the broad reproductive health world out there in the community, including infertility and IVF practices, because I really feel like that's, as I brought up in my opening comments, I really feel like that's an emergency. There are more and more private equity takeovers of infertility practices, and as soon as they get taken over, they no longer we've seen that in the Seattle area. We used to have multiple practices, now we're the only one. They no longer will take VA insurance because of the complexity of it, and that's happening all around the country. And I think we really, ASRM and in conversation with the VA, really needs to have a sort of a marketing campaign or something to say, you don't understand the privilege you're missing in taking care of our veteran population. And our responsibility to do that. And I think that part of that, in people taking that up, will be understanding that, but also be simplifying the process. I mean, it's just a necessary component to bring more people into the world of caring for our veterans.
Dr. Ryan, thank you for those comments. It strikes me that maybe one of the things we could do is maybe prepare a letter from members of Congress to the infertility clinics that are owned by private equity, those that don't accept veterans. And so maybe we can formulate a letter from some of us that would inquire appropriately. Like, wouldn't be just an inquiry, it would kind of, we can think about how we would phrase this, but thank you for that. Rep. Underwood.
Thanks so much. I just had some questions around costs and related costs for those individuals who are able to access care for whatever reason. Like, are all the medications covered? is all testing covered? Can you talk about what might be available that then, or is not available within a larger VA network that then it's on the responsibility for that veteran to figure out where to go and how to pay for it? I just have some of those kind of technical and logistical questions. Thank you very much.
Go ahead, thank you. Dr. Ryan.
So the coverage under Directive 1334, the IVF coverage, is very good coverage. It's just very hard to get. It does cover, and the one, I think, unique thing that is I think confusing for folks is, while there's no longer a requirement to be married to a heterosexual spouse, you do have to be married to that heterosexual spouse in order to get the coverage for that spouse. So that's an important thing, I think, that gets a little bit covered up. Like it seems like that went away. It didn't really go away. You still have to be married in order to get. So if you're a male veteran who has a service-connected disability, you have this 1334 coverage, but if you're not married to your female partner, a lot of the expense is still there. Because those are expenses for the female partner, and if they don't have a collateral, if they're not a collateral spouse because they're not married, they're still. So, but assuming that you have a heterosexual couple that are married and have met, one of them, the veteran, has met the service-connected, it is good coverage. It's up to 6 egg retrievals and 3 embryo transfers, although if you've made it to the 3rd embryo transfer, you can't go back and get any more egg retrievals, which is strange. And also it should be perhaps fewer egg retrievals, but all the embryo transfers that you need for a number, and we could talk about that too. But it does cover all the medication costs, any related testing, genetic testing of the embryo or carrier screening beforehand, any surgical things that are required to optimize outcomes. So it's, there's some unique things in it, but in general, it's quite good coverage if you're able to get it.
So I think Dr. Ryan did a terrific job about what is currently covered. What I want to talk about is for those who do not have coverage, what the costs look like. And, just again, I'm a 2-time IVF mom. I'm the spouse of a veteran. We did not have coverage. I'm very lucky. I have 2 IVF children. I love them dearly. But we had to pay entirely out of pocket. We went through 3 retrievals, 3 transfers. Our out-of-pocket costs for all of the medical expenses, the medications, totaled up to about $70,000. That is a lot for any American. It's a lot for veterans. And that impacts what your quality of life looks like when you get out of the service. We delayed buying a home because we had to dip into our savings to cover IVF. And I think the point that I really want to underscore here, and we've talked a lot about the service-connected disability piece here, is that IVF is only expensive for veterans who go and seek out community providers because there is no insurance coverage. And that's, what I think this committee and Congress can really help, and that's why we push so hard for mandates. Back in 2015, ASRM, in partnership with SART, the Society for Assisted Reproductive Technology, we actually launched a program called Serving Our Veterans. The whole goal of the program was to encourage clinics to voluntarily provide discounts to veteran families. We were really disappointed. The uptake was very limited. The discounts were not incredibly, generous. They were maybe 10 to 15%, which, perhaps helped some families, but it still made IVF very cost prohibitive for many veterans. And we are glad to see that many clinics do continue to offer discounts for veteran families today. The discounts sort of range, and I think this is something Dr. Ryan really pointed out as well. Those types of programs, they're not available in every state, and it contributes to the access and the affordability challenges.
Georgette, you made me start thinking about why members of Congress and the staff have access, and it's because of the DC law that governs the exchange that we have here, but it varies from state to state,
Correct.
right?
Yes, I believe it's 16 jurisdictions have implemented IVF mandates, and that's why you have this sort of patchwork of coverage. And when we went through IVF, we actually lived in DC on a military base at the time. I actually testified in the DC Council when the law was moving through committee to provide that coverage in DC. It did not go into effect until January 1. 2025, but in DC, in Maryland, we're one of the lucky ones. If you're in Virginia, no such mandate. And so we see this across the country, and that's why we at ASRM believe the most equitable way to ensure that every veteran in every state has access is to mandate it.
So congressional staff, members of Congress, okay, and then
Federal employees, they're
federal employees.
a little
under
different, yeah.
under the
They're
FEHP.
exactly.
And then TRICARE is, I mean, it's not the best, but it has some.
So TRICARE is very similar to VA system. You still have to have the service connection. And that's why I think that there's an opportunity here to push on both the DoD and the VA side simultaneously. We got dangerously close in last year's NDAA cycle. At the 11th hour, we had a TRICARE mandate for active duty service members in the NDAA. It actually was drafted, so it intentionally achieved parity with the mandate for the coverage that members of Congress get. So medications, 3 egg retrievals, unlimited embryo transfers. At the 11th hour, the speaker pulled it out of the bill. 3 days later, ASRM, working in partnership with Congresswoman Jacobs, as well as partners across the aisle, reintroduced the bill, the language, the exact language that was pulled out of the House bill, expanded to cover Coast Guard since we couldn't do that in NDAA.
I'm sure members around this table are getting some ideas here. So
yeah,
like,
I'd love to.
I can just see a bill that's saying we need to guarantee our veterans get the same access
as members of
fertility
Congress.
treatments as members of Congress.
Exactly, and we have standalone legislation for active duty, and I'm thrilled to report we have 11 House Republicans that have now co-sponsored that bill.
I think this is where we need to go. All right. Besides making sure Ms. Brownlee's bill and Ms. Morrison's, but I mean, it's like, I can see it already. Who's next? Is it Kayla? Kayla, and then Carla. Carla.
Thank you so much. Representative Underwood, to answer your question, I also wanted to mention that while Dr. Ryan is completely correct that for eligible veterans, the coverage is quite good, lack of understanding of the full covered benefit in different pieces of VA can still cause problems. So if pharmacy doesn't understand exactly what's covered, veterans who are anxious to move the process along in a timely manner may still end up paying out of pocket rather than wait for full understanding across every single piece of VA to catch up. And the same can hold true for things like cryopreservation. I'd also like to just kind of foot stomp what Dr. Ryan mentioned about the issue with the 6 retrievals, 3 transfers, and would it make more sense for that to be swapped perhaps? But just to encourage digging a little deeper on whether the numbers make sense in every case.
Kayla, Carla.
Thank you, Georgette. To pick up on that, the DC mandates at least 3 egg retrievals with unlimited transfers, and Dr. Ryan can speak to this a lot better than I can, but the hope is that patients won't feel pressure to transfer all created embryos in a single transfer in order to avoid multiple pregnancies that put the risk of the pregnant person and the fetuses, put their health at risk. And I'll also mention that the DC mandate also covers embryo transfer to a third party, which is something that I heard noted by somebody else. So a couple, either a single individual or a couple who use a person acting as a surrogate, still has coverage for the medical treatment for that transfer to a third party, as well as standard fertility preservation. So thinking about parity between veterans and members of Congress, and also noting that the DC mandate also mandates coverage under DC's Medicaid program, which is something that is woefully missing in the large scheme of things in terms of state-level mandates that really prioritize private coverage over public health programs. So just to reinforce the need for parity in order to get veterans
So
the health
DC
care they
law
need.
does require parity in the Medicaid?
Yes,
As well,
it has.
so it's mandated, and the shared responsibility for Medicaid, the DC law emphasizes that benefit among Medicaid.
They also provide fertility health coverage in the form of ovulation enhancing medications, as well as standard fertility preservation for Medicaid beneficiaries.
This is making me think about the drug issue related to VA's formulary. And has there been negotiations with the pharmaceuticals over making these drugs? I mean, that's another thing we could look at.
If I can just also add, I do think that the DC parity is a good concept, but there are holes. And so I think that in preparation for whatever this committee might consider, it would be important for you as experts to be specific about what you would want to see where the holes need to be filled, because I know that there are issues for this, like PGT testing. There are issues with some medications. There's just challenges, and I think that if we can be intentional from the beginning about filling those gaps for a veterans mandate, that would be very positive. Mr. Chairman, thank you so much for the time.
Dr. Conaway.
Just I think a quick question, maybe not. I was surprised, and perhaps Ms. Ross, because of the service of veterans in Afghanistan and Iraq. There's something particular going on there, but I was surprised at the number of people who reported disability practice in 30 years. I have not run into that many people. My own experience, my wife and I had some issues with it and went through IVF, and turns out we didn't need it, but I do have some personal experience with it. This is for anyone. Why do we? I mean, obviously, there's trauma to a reproductive organ. That makes sense to me. It might be service connected. What evidence, what data has been gathered to explain this, what sounds like a high degree of infertility among veterans? Does anyone know or have are there some theories on this topic?
Sharon, and then Dr.
Well, yeah, Dr. Ryan can answer this one, but I would say what evidence there, none, and that exactly is the problem, is that we don't have extensive research. We have very little research, actually, on first the veteran population as a whole and looking at them specifically. And then when we start digging down even more into veteran population, breaking down by demographics, that just isn't out there right now. So, which hence the earlier conversation is just to push for some of this data, this research, so that when we start creating policy, we're doing this based on evidence and not ideological vibes going on at the current time. Thank you.
Dr. Ryan.
I think probably the question of research at the VA is one that needs a whole nother roundtable. So from 2014 to 2020, I was a PI for a project that has had some of the data come out that people have commented on, where we did interview 3,018 veterans, male and female veterans, and the specific goal of the study was to try to explain why we think that there is an increased risk of infertility. And so we have 9 modules of questions, including sexual assault, combat-related trauma, environmental exposures, childhood trauma, PTSD, and that we're starting to get that data out, and that's where some of those numbers are coming from, where we're seeing upwards of 50% of veterans reporting that they've had 12 months or more of unprotected intercourse in their lifetime without pregnancy. And we have published on the toxin exposures. I think it's such a complicated question, especially for female infertility. And when we're talking about self-report, it's a little bit tricky. But we again are seeing these contributions with PTSD and sexual assault and lifetime trauma, and again the environmental exposures. And I think those things are just hard to connect directly to something like. I mean, it's so much easier to say, yes, there was an ideate explosion and there was testicular trauma and, and there's a problem with the sperm. It's much harder to say this person had cumulative trauma and environmental exposures, and we don't have a way to look at what that does to the egg or what that, we know that sometimes there's a pretty straightforward traumatic brain injury and then you have ovulatory dysfunction, but there can be subtle changes in that we just don't really, our science is limited right now to see those connections. But there's clearly something there because study after study has shown these increased risks. And I would just comment briefly that it is very difficult to be a civilian researcher and work with VA data. So I think there's two ways you can be in sort of the small world of full-time at the VA researcher, which is a difficult world to be in for women's health in a very small world, or you can try to be a civilian researcher and it's very difficult to access those data. So that's part of the reason I think it's so important that we start to, as a variable, know about all of our patients if they have military experience, so that we can get at that question as civilian researchers, perhaps. But anyway, again, for another time to talk more about that. But that's what I know about.
Another time to talk about which, because this question of why it's so difficult for civilian researchers to work with VA data obviously has broad implications outside of just this particular topic area. And with Chairman's indulgence, and if you would like to expand on that just a little bit, why there, because perhaps we can intervene and help with the kind of collaboration that ought to occur to deal with the very broad range of issues, health issues that impact our veterans, and the need for research to understand what's going on.
Well, I guess I can speak to my experience. So to get a large study at the VA called an IIR study, you have to be 5/8 at the VA and have a clinical position at the VA. There is not much of a call right now for many gynecologists, let alone reproductive endocrinologists, to be employed at the VA. So it was a great opportunity for me to have that, but I think that's when Dr. Christie and I were the only REIs in the VA world. There's just not much of a call for that. And so now I'm back into the community and I have a .1, and that is also tricky. They're actually right now doing head counts, which include anybody with just a .1, and trying to decrease head counts at the VA healthcare system. Sorry, 10% of my time is at the VA. Yeah. So, that is only clinical time right now at the VA. So it's sort of on my own time that I'm still holding on to trying to get the data out for the research project. But still, my position is in jeopardy because of this, trying to get head counts down at the VA healthcare system. And since I'm only a .1, or only a 10%. That might go away. Similar to my male fertility colleague, who's a urologist and has only 10%. That's also on the chopping block as sort of a, and without any kind of clinical position at the VA, then you have to have a without compensation appointment, which is incredibly onerous, and they don't give those out easily, especially, well, my personal comment on that would be it seems especially for women's healthcare research. So if your particular VA health system doesn't have an active research in that area, then they are not excited. They have a limited number of without compensation positions. So that's just my experience, but some of the challenges.
So we're kind of running toward the end of time, but I want to get a couple of other questions that are relevant to this topic in. So I do want to move on to another question, if you don't mind, Maureen. This is for the clinician participants as well as the GAO. What are the challenges in care coordination in getting veterans access to IVF services outside of VA? What are the challenges that you see happen most often in your practices? The care coordination and getting that veterans access to IVF services outside of VA. What happens most? So, Dr. Christie?
As someone who practiced in the VA and was involved in policy, there are a number of challenges. One is there are different care models, and every VA medical center, it's not possible for women veterans to get a women's veterans healthcare provider. And so there's great variability and inequities in terms of referrals through the system. Also, care that is a hybrid between the community and the VA can be very challenging. And one of the things that was done was the creation of maternity care coordinators, because all of the obstetrical care is in the community. But one of the real challenges with that, and it also speaks to the researcher, is it's often very, very difficult to get medical information from the community providers. They're not required to provide the medical documentation, the medical information, detailed medical information in order to get reimbursed. And so when Representative Underwood was supporting the efforts to improve maternal care within the VA, it was very challenging to get accurate information about medical complications of pregnancies for veterans, because all that care is in the community. And so all of the infertility care, for the most part, is also in the community, so it's very difficult for us to get the information and therefore to coordinate it. And it's also a challenge in that many of the providers in the VA sought employment in the VA because they didn't want to take care of women. And they didn't want to be involved in infertility care. So there is also great variability in the commitment to coordinating the care.
Thank you. Ms. Hundrup?
Yes, thank you. In our ongoing work, I want to take one step back before the coordination with the community and just underscore a point about the infertility interdisciplinary teams and just the great variation there, which can lead to delays and confusion in terms of the composition of those teams and just how that coordination works and getting to that point finally where they can refer that care to the community. And some, issues there. But once they do get to that point and they have the referral, we're seeing just points that have been made, but I want to underscore the limited number of fertility clinics, especially in rural areas, and the limited number that are willing to accept VA patients and VA patient rates. And then, of course, longer distance times that result from that. Just to put a data point on it, preliminary data that we've seen from VHA in terms of just referrals, the average wait time is at least 25 days from when a referral is entered to get an appointment, and then at least 50 days from when the care appointment is scheduled in the community. And obviously, we're talking about a very time-sensitive point for that, so thank you for that.
Thank you. Dr. Ryan? And then you.
Yeah, I would second all of those points. As being on the IDT at Puget Sound, we, I just think we're such a unique situation where we can, look at some of and a few of the veterans here have commented on the adjudication being so clunky and inaccurate. We get something that somebody actually had infertility in service, but they're service-connected for female sexual arousal disorder, or it's just not accurate, or it's not captured. And so, but we have a very passionate IDT, and we're lucky to have the experience to say, actually this person is service-connected for sleep disorder, and and there is science between that and their ovulatory dysfunction, so let's get them service-connected. We don't, that doesn't exist, elsewhere. And so, and again, we hear from veterans time and time again that their efforts, and we also have, again, a lead, our lead from the community care has a JD, and she is out there helping every veteran to say, look, you need to, find your records, this is what we need to see, let's pull the rating sheet. That doesn't happen elsewhere very often, despite, very motivated folks out there in the community. So that's definitely an issue. And then I agree, again, the limited clinics, and then you have the referrals are now for 6 months. And so it's not too infrequent that the referral, gets sent, and by the time the veteran even has the appointment, the time for the referral is almost up, and then it's up to them to go back to their community care office and ask for a renewal of their referral, and then, maybe if they got their partner a referral, the dates are different on that referral. And so I'm as a clinical medical director, I'm seeing this from both sides. I hear our financial access team is completely confused by, and this is, again, a clinic where we see a lot of veterans. They're confused, what's covered, everything has to be absolutely done in advance, including medications, because there will not be any reimbursement afterwards. And so it's just a different system from any that our financial access team or that our scheduling team is used to. So especially, I would say that the partner having a separate, it's not infrequent, unfortunately, that we go ahead with a treatment that should be covered for the partner, but we didn't make sure that that partner has a separate referral in place. I mean, I could just, I guess, go on, but so there are a lot of complexities, and it's difficult for each clinic. We, again, have a nurse practitioner who's in charge of our veterans. We have a financial access team specialist who's in charge of our veterans in the community, but that does not happen, and that's the only way, and we still make mistakes all the time, and we do not want to do that for veterans because, as also has been brought up, veterans with PTSD and what they've gone through in the past in the medical system, understandably, this is not what they want to face when they're walking in to the clinic and they've undergone this incredible, horrible journey to get there, and then they're told, actually, you have to pay out of pocket because we didn't really make sure your referral was in place because we didn't understand that it was up last week, and so it's complicated, too complicated.
Thank you, Dr. Bryan. Ms. Brownlee, I know you want to ask, she's going to get the last question, but Rita, you want to make a quick comment before I call Ms. Brownlee? Yeah.
To the fantastic points about the referral system, the new VA referral system that was launched this month will only make those days and those referrals take even longer and longer. Community care managers are complaining, my community care manager directly complained to me that they're being overworked with the new digital system with no end in sight, and they don't know how to even process these claims anymore because of the new system this month.
So Rita, I was just texting my comms person about contrasting what Dr. Ryan was saying with the Secretary's new initiative to speed referrals into the community. And so I had questions about that, but you kind of addressed it right there, reading my mind. Ms. Brownlee.
This is a quick question, and it's probably not a black and white but gray question. But I've been asking ChatGPT a lot of questions.
Why I've been same thing.
But in asking, just generally where do veterans get their information, in terms of infertility and what's the policies and so forth. Now I've just lost it, but let's see. Hold on, just, so the ChatGPT, anyway, says that the VA has a dedicated fertility service program that explains eligibility and treatment. And then it says, veterans enrolled in VA healthcare can receive fertility, counseling, testing, medications, and some treatments. And then it goes on to say for IVF specifically, it has to be service connected. But my question is, for all of the services up to needing IVF or other infertility treatments, is what VA is offering comprehensive?
So for the way I think of it simplistically is the 1332 directive, which is the medical benefits package that's available to all enrolled veterans, versus the 1334 directive, which is, again, the IVF limited, and can include a partner. I would say that the medical benefits package is pretty comprehensive. The issue is there's no possibility for a partner to be covered. So that can be a significant issue. But it
things
does,
like hormonal treatments and all of that, is that included?
Yes, so medications, surgeries, up to 6 intrauterine inseminations per pregnancy. And so that can restart even after a miscarriage. It's not exactly, I would say that for LGBTQ veterans who may need, who aren't typically exposed to sperm, so for gay women, it's not enough, I would say, for those veterans. The other issue, again, is the partner, but it's generally pretty good. The big issue I would say that just recently changed, which is maybe a subtlety but is a big deal, is that for veterans who have, obviously have access to the medical benefits package coverage. If they choose, but they can't have the 1334, the infertility, because we haven't been able to get them a service-connected disability. If they choose to proceed with IVF, the VA then takes away the 1332 coverage, which is ridiculous.
Makes no sense.
It makes no sense. Yeah, I know. It's something that they snuck in there in the last 6 months or so. And so you're tempted to have your veterans not tell their community care office that they. So for veterans who need IVF to whether they've failed the IUI, 6 IUIs, or they just have tubal disease or all the reasons for IVF, if they decide to proceed with IVF, but it's not covered by the VA, and the community care office hears about it, they will stop their medical benefits.
Wow.
So that's a big problem, and it has led to us. Anyway, I shouldn't say it on the record, but that's a real problem. But in general, again, for the individual veteran, and if they don't need to pursue IVF treatment, it is pretty robust coverage.
Comprehensive.
Yeah, when you just compare it to private insurers out there. Right, exactly. So if you're in our practice, which obviously accepts VA coverage, and we've been treating you under the medical benefits package, and we need to pursue IVF, and the veteran decides to do that, we try not to tell the community care office so they don't take away.
I think you're clarifying the letter we want to write to private equity. Seriously, I mean, it is comprehensive, sans what you just mentioned, except for that. But Rita, real quick, because then I want to give the last question to Alex. Okay, go ahead.
Just a quick point from anecdotally what we see, and not negating at all what Dr. Ryan said, but anecdotally what we're hearing from our community members is that they get denied for hormonal testing. They're getting placed on birth control instead. We have 40-year-old women getting put on birth control after requesting hormonal panels, and they just get flat out denied by their provider. So while it's offered comprehensive, whether or not it's being received on the VA user level is a completely different story from anecdotally what we hear.
So there's some need for oversight.
It's not surprising.
Yeah.
Oversight. So Julie, I lied. I thought you were going to be the last question, but I do want to ask the last question to Alex. So, Alex, what do you most want people to take away from your story, and how can your experience with seeking IVF at VA inform future legislation and the lawmakers here today? Alex?
Thank you, Mr. Takano, Congressman Takano. Probably 2 things I'd like to highlight. And some of the members of the committee and some of the other representatives have highlighted this as well. The need to examine the intersection between the new, the reestablished VA abortion ban policy that went into effect on December 31st, and also how that is affecting current IVF coverage. You can't simply talk about one without talking about the other. As Ms. Torres said much earlier on in this discussion, there are a lot of veterans who have needed both access to abortion care, but also still need access to IVF services. And I think that's a point that is oftentimes lost. Like in my situation, after having been raped, that was a very difficult decision that I personally faced, fearing that I was pregnant. But that does not mean that my value for life was any less. And my husband and I have, years later, upon getting married, we have been seeking IVF. We suffered through infertility, and after years of it, are seeking IVF coverage. But what I am seeing, and I'm still significantly plugged into veterans and active duty communities, most predominantly through the Air Force Women's Officers community. And women right now, because of current policies with this administration, are seeking permanent changes to their body and to remove their ability to have kids out of fear for their own life. And these are women who either don't want kids, or a lot of women who do want kids. And so you can't look at one issue without running into issues with the other policy. And there are so many veterans out there who want a family like myself and want to pursue IVF. But here I am, closely approaching 35 years old, with a guest bedroom full of baby stuff that I would love to be able to actualize and realize as my dream. But I fear for my life. So we are pursuing IVF. But that's still a conversation of, do we feel comfortable in the current state to actually go through the transfer process? So that's probably the big thing I want to highlight there is the intersection between these two issues. And then last but not least, what I would like for the HVAC community to maybe take from my experience, and I will push as my own like personal initiative that I would like to be examined, is a lot of this would be eliminated by Congresswoman Branley's bill to remove the service connection requirement. But if we aren't able to obtain that, expanding coverages to include mental health conditions, as so many people have talked about, PTSD is a huge problem within our veteran community, as well as MST is on the rise. Of all of my friends and colleagues that I have had a personal relationship in with my 10 years of service, only 2 that I know of did not experience MST. And I think if we as a country are pushing the initiative to recognize within our own country that mental health conditions are just as important as physical health conditions, then when it comes time for rubber to meet the road, it's important that we start looking at expanding coverages to include mental health conditions like PTSD, MST, FSAD, and even how erectile dysfunction can be impacted by these. And I think that is especially important in our veteran community when PTSD and mental health issues are so prevalent. I appreciate you hearing me out and taking the time to consider these issues. Thank you. Thank you to the committee for hearing me.
Well, thank you very much for that, Alex. I'm glad that we got to hear on your main takeaways. This intersection between the abortion access rule at VA and fertility treatment access. Help me. I want to go away with a way to be able to succinctly frame this for the public. But it seems to me it's in there is this the nexus is the idea of being able to care for miscarriages as an essential part of this question about whether VA or VA benefits are going to cover the possible complications of fertility treatments and whether a woman's life will be endangered by the policy that we have in place. How we begin to explain and frame that. Because on the one hand, we have, I think, very well articulated Dr. Morrison's call for gold-plated benefits for the men and women who serve our country, gold-plated fertility benefits. But that cannot be separated from a rational policy on abortion access. And so we need to make that, I think, more clear. Sharon?
Hi, thanks, sir. So I actually just, I've testified in Congress before this regarding abortion access for our service members, post-STOBs. And I will say that, I know I sound like a broken record, but it has to be evidence-based. And our push has always been that IVF, right, when we talk about reproductive health care, it is the entire continuum of care to include access to safe pregnancy management, right? Again, reproductive health care, reproductive medicine includes access to abortion as well. And it's an entire package. We can't separate them without offering the other. So, and I know that the abortion issue is a very emotional one for many people, right? And it is one that, people have very strong ideas about it. And I will go back to my colleague Kayla, where it's at the end of the day, we don't impose our ideologies on other people. Again, a decision between what I get to do with my body, the decision of what I do, besides family building or not, should rest between myself and my medical provider. And that is a sacred space where our policymakers need to make sure they're protecting that sacred space. And right now, those protections have been stripped away. Thank you.
Dr. Christie?
Start by saying women veterans will die as a result of this policy change. The reason the previous Secretary of VA made it life or health of the mother is it did not put the physician in the position of saying, if I don't do this, the person will die. Would we ask a surgeon to diagnose appendicitis and say, you can't operate unless the patient will die? And because these are young, healthy people, they keep their cardiac reserves, their blood pressure doesn't drop, their heart rate doesn't go up until they're very close to death. And so there will be people, physicians who will delay, as we heard earlier, providing the care because they're afraid that they will be prosecuted and incarcerated for providing medical care. States that have, the heartbeat bill, so if someone has an ectopic pregnancy, a tubal pregnancy, and it happens to have a heartbeat, the pregnancy is not going to survive. It's not viable. But if there's a heartbeat bill, you can't do the life-saving surgery to save that person. If someone has a miscarriage and hasn't passed and they get infected, but there's a heartbeat, they can't give them the medical care they need to save their lives. If someone is a cancer patient and they need to terminate the pregnancy in order to start cancer care, they can't do that. That's why it needs to be life or health of the mother, not just life, because what they will also do, and we know this because they ask for these records, what they will do is Monday morning quarterback the physician's decision and say, oh, they wouldn't have died, and now we're going to criminally prosecute you. So women have died as a result of the Dobbs decision. Women will continue to die as a result of the Dobbs decision. And so these policies are not Christian, they're cruel.
Thank you so much. I'm going to call on Georgette briefly, and Carla briefly, because then we got to wrap.
Yeah, and
Go ahead, Georgette.
I wanted to share my personal story to highlight Dr. Christie's point. IVF certainly improves the odds for a veteran or any patient to have a family, but it's not a silver bullet. I mentioned that I had 3 transfers to have my 2 children. My first transfer resulted in miscarriage, and I ended up in the hospital. It was New Year's Eve 2021, so it was the perfect end to that year, with an emergency procedure. My husband couldn't even, come in with me because I had a miscarriage and it was infected. I had a blood clot the size of a lemon in my cervix, and it was very dangerous. And so that, pregnancy, that miscarriage was the direct result of IVF. And I thank God every day that I was in a state where I had access to the services that I needed. I was grateful that my IVF provider helped me work through that and get to my next transfer that I needed to build my family. But I can certainly understand Alex's fear about this, and it's a shame that Congresswoman Brownlee left. I wanted to thank her, too, for her work on the CRA resolution. We are expecting a vote in the Senate on the CRA. ASRM has endorsed both the House and Senate CRAs. We are, I guess, disappointed that the rules do not necessarily make that privileged here in the House the way it is in the Senate, but we do think it is a tremendous opportunity for this committee to highlight the dangers of that new VA rule, as well as its connection to fertility care, including IVF.
Thank you, George. I'm looking at ways to do that so that we can coordinate with what the Senate's doing. Carla, quickly.
Yes, just to say that, abortion and IVF are deeply interconnected, and we know this from our own litigation. We have represented a client in Texas challenging that state's abortion ban who was denied abortion care because there was still fetal cardiac activity, who suffered from sepsis, who needed emergency care that kept her in the ICU for 3 days fighting for her life. And when she woke, she found that one of her fallopian tubes was permanently blocked, and that in order to pursue her desire for a family, she may have to turn very likely to IVF and other assisted reproductive technologies. Denying abortion care to pregnant people absolutely may risk their fertility, and people who become pregnant through IVF may suffer pregnancy complications, like Georgette and so many others who will need timely abortion care. We know from our litigation, from our research and fact-finding in states like Texas, Oklahoma, Louisiana, that exceptions do not work. They act as total abortion bans, and they are a gross human rights violation of every pregnant person who needs timely, evidence-based medical care to safeguard their health and future fertility.
Well, thank you. And we have to call this a wrap, but this final testimony, I know we've probably captured on video, but you've given me the language and the clarity to be able to talk about this topic, and I want to get it to my colleagues. Your participation today has been a tremendous service to this committee, we've come away with a number of action steps that we can take to move access to the full range of reproductive health care possible. And so your expertise and testimony was invaluable. I appreciate it. Thank you so much.